Chairman, dear colleagues, ladies and gentlemen. Maybe you are familiar with this recently new diagnostic tool in ENT practice. The aim of this small lecture today is just to letting you know what is the clinical use of that new diagnostic tool. What is actually Beam and how does it work? First of all, let us remind that first scanner was introduced in medical practice in 1972. 10 years later, Beam technology was developed in biodynamic laboratories in the Mayo Clinic in USA. Invention of the CT was awarded by Nobel Prize in 1979, Sir Godfrey Hounsfield and physicist Alan MacLeod-McCormack. American physicist McCormack developed mathematical equation which enable us to see reconstruction of the image on the computer screen. Technically, what is the main technical difference? Cone beam, so-called cone beam geometry, is that X-ray in cone beam shape go through the object that is object of imaging, and only for a short period of time, for one beam, it is sufficient to get enough data to have perfect image screen on the computer. A fan beam geometry, we know that as multi-slice scanner, need a lot of slices. It is time-consuming and lasts far more longer until the computer gather all data to reconstruct image. CBCT, as defined and as confirmed by Food Drug Administration in USA, is actually a variation of traditional computed tomography systems. It is a cone-shaped X-ray beam gantry which rotates around the patient. At the same time, it captures image data. Through sophisticated software, it was processing, and 3 image data could be reconstructed if needed. 2 decades ago, our colleague from dentistry accepted this diagnostical tool, and oral and maxillofacial surgeons too, but in the last 10 years it was accepted for useful tool in the diagnosis of ENT diseases. What is the main difference in between 2 scanners? If we are talking about the amount of radiation of the patients. CBCT has a quicker motion and it is less time consuming. Far longer time need the spiral motion of the gantry in traditional CT scanner. What this practically means? It is schematically here on the screen. It practically means that our patients receive up to 6 times less radiation doses for ENT field, up to 22 radiation doses for field of 1 sinus. In multi-slice CT, imaging process lasts longer and patients receive much higher X-ray doses. We are using nowadays 2 types of CBCT machines. Usually, there are in everyday use machines with seated position of the patients, because it is a highly and fastly developed technical equipment. On every congress we witnessed some new equipment that appeared. Like in the last World ENT Congress, where Italians presented their machine for the supine positions. In our clinic, where I'm currently working on, we have experience with Sorodex Finland Scanora system, which is recently under the patronage of very potent and very powerful CAVO advanced CBCT system technology from Germany. CBCT radiation field for ENT region is 13 to 15 centimeters. And it is quite enough for us to gather enough data if we are trying thorough analysis of all landmarks that we needed, first of all, to make a secure operational plan in order to avoid all hazards of the fast surgery. As postulated by Professor Stamberger more than 30 years ago, the golden standard for preparation of endonasal surgery is so-called endoscopy, then analysis of the computed tomography scan on coronal plane. Is it possible to achieve that golden standard with CBCT technology? Thoracic scanora system, by our experience, give excellent insight into all three sections. And we can analyze 1 millimeter section slices if we want to go thoroughly through whole sinus volume. And what is more, sophisticated software enable us to measure precisely the volume of the aeratic spaces of the nose and nasal sinuses. It is actually a new diagnostic tool. It's very useful, as confirmed by recent studies, first of all for diagnosis and treatment of obstructive sleep apnea, and precise determination of the site of airway construction. What is with Scanora 3D and ENT diseases? Finnish authors were first who described clinically in the serial of studies what is the advantage of this method. And the advantage is that radiological images were at the good quality. They were generated under the low radiation doses at the reasonable low costs. In our clinic, 60 patients with chronic sinusitis without complication were subject in these studies. The important radiological landmarks were independently analyzed by 2 experienced ENT surgeons, like extent of disease, presence of anatomic variation, visualization of bone structures and borders of the sinus walls, and of course, presence of the scar tissue. Each item was scored by questionnaire, and results were analyzed in the semi-quantitative manner. The quality of the CBCT image was good enough for analysis and to fulfill all the conditions which thorough analysis, preoperative analysis need. Analysis of the nasal cavity anatomical details in a coronal view was possible, first of all, from the starting point, which is the position of fovea ethmoidalis, lateral lamella, in position of lamina cribrosa. It was excellently possible to analyze by CBCT. Even we can measure the height of the lateral lamella and label it and keep it in the operational theater on our computer. And during the operation, we can see, especially the complicated cases like this in our patient who had asymmetry of the lamina cribrosa. One side was a Keros 2 type and the other side was Keros 3 type. Other anatomical variation like concabulosa, Haller cell, deviation of the nasal septum, then conditions of the nasal mucosa and sinus mucosa were possible to analyze too. Especially it is a very useful tool because of the low radiation dose. You can follow your patients with severe cases of allergic rhinitis. And of course, patients with nasal polyposis. In our clinic, we often see patients with the condition so-called dentogenous sinusitis, like in this lady who had dental implant, and 2 months after that, she developed severe unilateral maxillary sinusitis. And of course, a part of the dental implant was present in the sinus. According to results of our study, anatomical variation was present at the same frequency as in other clinical studies. The results are in agreement with the findings, as well as with CBCT and classical CT studies. And our observers concluded that CBCT showed well-defined extent of disease with a very high score. With a high score they marked anatomic variation visibility as well as anatomical borders in bony structures of the sinus walls. Poor scores were reserved for the scar tissue. So the clinical studies and our study confirm that the most frequent indication for CBCT ENT should be chronic rhinosinusitis without complication, cyst of maxillar sinuses, nasal polyposis, and follow-up of the patients with chronic sinusitis and intranasal operation. It was the patient who has been operated on other clinical center and came to us insisting on reoperation. We concluded after analyzing CBCT that maybe he was over-operated first time, but he has complaints. He has postnasal drip, cough, and cephalia. After having thorough diagnosis, these patients had actually reflux disease. Is it possible to analyze frontal recess? We know how important is frontal recess for endonasal sinus surgery. It is. You can perfectly visualize everything with CBCT. So the main advantage of CBCT over standard CT is low doses of radiation and short period of time for short imaging process. Low radiation doses and low costs. It means shortened preoperative period. Our patient came to our morning clinic, we send him to make CBCT, and during the same day, or maybe day after tomorrow, he brings you result, and you can start with the planning. Disadvantages of the CBCT are, it's not suitable for the patients in intensive care, and the small children too. Not for the patient with tremor and locomotor disorders, because we need our patients to sit perfectly still for 2 minutes. It's not reliable for the patient with suspected iatrogenic complications during endonasal surgery, and of course for the patients with sinusogenic complications. So in a conclusion, we can say that apart from all advantages of CBCT, which are obviously documented by the recent studies and by our study, multi-slide CT is superior in diagnosis, in reconstruction of pathological findings, especially in sinusogenic complications. And at last, I have to be, and all my colleagues at the clinic, very thankful for the support and help that we had from the Faculty of Dental Medicine. We are educational center for the Faculty of Dental Medicine, and 2 gentlemen who were software specialists who helped us to learn how to use a sophisticated software that was embedded in the CBCT system. Thank you very much.